So first we have the CAP PIP for cytology, non-gynecology, cytopathology educational question. So the first one is from a bronchial brushing. The patient is 68-year-old female who had a history of smoking, and she experienced hemoptysis, and the CT scan show a large central lung mass with associated mediastinal lymphadenopathy. So this is a bronchial brushing specimen, which is relatively uncommon here in our hospital because our chest medicine department, they have their own cytology service. So they rarely do the brushing, but they still do the lavage. But they examine their own specimens, so usually we won't get this type of specimen. So on low power, we can appreciate that it is a hypercellular specimen, and we do see a lot of fragments of very dark cells. And when we go to higher power, we do see it is a significant crashing artifact for these cells. The cells show hyperchromatic nucleus and a very high NC ratio. And when we go to higher power, we can appreciate that the cell do have very delicate chromatin pattern. So the chromatin pattern is like it's almost like powdery, and you cannot easily tell the granularity. It's like a very fine granular type of chromatin pattern. So along with the high NC ratio crash artifact and these type of salt and pepper chromatin pattern, this is consistent with a small cell carcinoma. And despite the gender of the patient in the history, she is a smoker and has been smoking for a long time. So occasionally we can see small cell carcinoma in female patients. So this is consistent with small cell carcinoma. And for the small cell carcinoma, it is very common that you can see some necrosis in the background. So the first specimen is a small cell carcinoma. So the second question, this is a 66-year-old male, and he had mass in the kidneys. The mass is 8 centimeter, and this is the aspiration cytology of the kidney mass. So we also rarely receive this type of specimen because for a kidney mass which is already 8 centimeter here in our hospital, most of the time they just directly do the nephrectomy. They can either do nephro-sparing partial nephrectomy if it is in the like a bilateral pole, or if it involves the collecting system in the medullary, they can do the radical total nephrectomy. So in this specimen, we see fragments of the cell with tight cohesion. So the most common type of renal cancer would be clear cell renal cell carcinoma. However, we still need to remember that in the kidney, there are still a chance that there is urothelial carcinoma. So just based on the morphology, I think it is relatively like indistinct for renal cell carcinoma, because in renal cell carcinoma, usually we would expect to see a lot of bubbly cytoplasm. And in this specimen, it does show a more like a syncytial squamoid type of feature. So I was wondering, could it be a urothelial carcinoma just based on the morphology? Additionally, we also see this papillary type of growth pattern. However, it is uncommon to have an 8 centimeter mass of urothelial carcinoma because we know for the urothelial carcinoma, it arises in the urothelium. So when it develops a mass lesion, it's already you can have some obstructive like symptoms. And so yeah, so then I go to their website. They do provide immunohistochemistry, and the epithelial cell were diffusely positive for PAX8. So if it is positive for PAX8, it is consistent with renal cell carcinoma. So based on the cytomorphology, I would say this is very untypical, not typical for for renal cell carcinoma, because usually we will see abundant bubbly clear cytoplasm and prominent like enlarged nucleus and prominent nucleoli. But in this case, we see mostly syncytial and the papillary pattern. So this might be a papillary renal cell carcinoma, but the cytomorphology is kind of indistinct. So the next specimen, this is coming from Pura effusion. The patient is 64-year-old. She had a history of breast cancer. So because of history of breast cancer, on low power, this is a liquid-based cytology specimen, zinc prep preparation, which is we rarely use this preparation, so the morphology might looks a little bit different. But in this specimen, we do see some aggregates of the cells. So for the body fluid specimen, I usually prefer the cytospin specimen because it can nicely preserve the cytomorphologies. For metastatic breast cancer, we expect to see either cannonball pattern, just a ball of the tumor cell, or individual cells with sort of like Indian fire type of pattern. I think for this specimen, the pattern was not very well demonstrated, and in the background, it's quite difficult to tell whether these are mesothelial cells or tumor cell. But we do see like a focal cell show more prominent like a cell ball type of pattern, and more prominent like a nucleoli. So it's likely to have a metastatic breast cancer in this specimen. So on the website, the lesion was positive for GATA3. So we usually do a GATA3 here in our hospital as well. So this is positive for breast cancer. Today we have our own cases. We have 2 or 3 cases, so we will see our cases is more beautiful than the CAP's question. Yeah. The fourth case is thyroid aspiration cytology from the 38-year-old female. So this is kind of typical. For this case, we only have a diff quick scan. So on low power, we see tons of cells, mostly individual cells, small, looks like a lymphocytic cell. We don't have colloid in the background. So I would say the diff quick scan, because it has a step to rinse with the alcohol. So sometimes the nuclear feature is more well preserved than our loose stent. So for this specimen, we see in the background lymphocytes, and we do see cluster of cells, looks like epithelial origin, and the cells show prominent, like abundant cytoplasm, enlarged but rounded nucleus. So this cell looks like oncocyte. So if you see prominent lymphocytic background plus oncocytic follicular cells, this is a Hashimoto thyroiditis. So this is very typical for Hashimoto thyroiditis. I think our specimen doesn't show these beautiful like a Ginza type of stain. So it is nice to see sometimes the other preparation may be better. And this is one of the examples. So this deep quick stain nicely show lymphocytic thyroiditis. Yeah, so this is relatively easy. So finally, this is a urine specimen. So this is a cytospin specimen of I think it's a washing cytology. Yeah, catheter urine. So the patient has UTI, and this is her catheter urine. So because it is instrumented, we will see cohesive fragments of the cells. So this is derived from the catheter, from the washing or from the catheterization. So you can see some fragments of the cells. And these cell fragment, if we take a look of the individual cell, particularly the cell around the nest, you will see prominent, like abundant cytoplasm. So with a very low NC ratio, and at the periphery, it seems to be there are some umbrella type of the morphology. So these cluster all looks benign. And in the background, we don't have any high NC ratio cells, and we don't have any microorganism, because in the question they were asking, is there any like HSV or CMV? We don't see any microorganism. So this is consistent with a negative specimen. So based on the Perry system, this is negative for high-grade urothelial carcinoma, and we do not see any other microorganism in this specimen. So for the catheter urine, sometimes it's a little bit confusing because you see hypercellularity, you see large fragments of the cells, but the key point is that we need to identify whether there is any morphological feature of high-grade urothelial carcinoma, including high NC ratio, hyperchromasia, polymorphism, coarse chromatin. We do not see any of these in these cell clusters, so this is a negative specimen. So going back to our own cases, first specimen, pleural effusion coming from a 54-year-old female. So this is hypercellular, and so with this cellularity, we will go to the more like a thin layer area. So on low power, we can appreciate that we do see it's relatively a monotonous appearance, and I think the nuclear is darker than the usual pleural effusion specimen that we will see. So when we go to higher power, we see like a relatively monotonous cells, and mostly in individual. And however, majority of the cells do show some nucleoli, and this is relatively monotonous. And then we start to see these cytoplasmic vacuole. So when we go back to the requisition sheets, the patient had a history of invasive lobular carcinoma. So this is very similar to a case that we see 1 or 2 weeks ago. There is an older female. We see initially her ascites specimen with scattered signaling cell appearance. We saw that it is coming from the stomach, because in the CT, the patient do have like an irregular thickening of the stomach. However, it turned out to be a lobular carcinoma from the breast. So this is very similar to the specimen that we received 1 or 2 weeks ago. So we see mostly individual cell and occasionally some vacuolization in the cytoplasm, but we also see prominent signaling ring cell, like a very, very scattered prominent signaling ring cell. So in this situation, we just need to remember, For invasive lobular carcinoma, it can present with this type of morphology in the body fluid specimen. So this is positive and consistent with metastatic lobular carcinoma, and majority of the cell that we see here are tumor cell. So most of the cell here are tumor cell. So the next specimen, also from a female, the patient had an invasive ductal breast cancer. So different. The prior case is a lobular cancer, and this patient had a ductal cancer. So for a ductal adenocarcinoma, it is more common that we can see a cannonball type of pattern. So we start to see these small tight aggregates of the cells arranged in a three-dimensional ball. And for ductal carcinoma, it is not uncommon that you can find some squamoid feature in the tumor cell, including hyperchromasia and coarse chromatin. But the morphologic pattern arrangement do show this typical cell ball type of pattern, cannonball type of pattern. So this is positive for metastatic carcinoma, and the pattern is consistent with invasive ductal carcinoma. So these are two different breast cancer and with two different cytomorphologic presentation. Next patient, this is a pleura effusion specimen. The patient had a history of ovarian cancer, and it has been proven to be a high-grade serous carcinoma. So this is her pleura effusion specimen, so above the diaphragm, and we have a cytospin preparation. So for this specimen, we only have very, very scattered highly atypical cells in the specimen. So for this case, you can see these nuclei look like a kidney shape and very big, and it has two irregular nucleoli. And there are some other cells arranged in tight cluster and with abundant, a little bit like a vacuolated cytoplasm. So this is consistent with a high-grade adenocarcinoma, given these high-grade nuclear atypia, very big nucleus. So we only have a few cells in the specimen, and the preparation is not ideal because there are some significant overlapping of the cells. But here again, we see this very big cell, nucleoli is prominent, and cytoplasm shows some vacuolization. So this is positive for metastatic adenocarcinoma. I just want you to pay attention to these cell block preparation. So for these cell block preparation, we have very, very scant cellular component. And for our cell block, usually we will have two sections. This is one section. This is another section. So when we take a look at this section, we see some cells with much like a pink granular cytoplasm, and we do see a little bit prominent nucleoli. However, the cell does not look like what we see in our specimen, in our cytopene preparation. So this actually looks more like a hepatocyte, liver tissue. So this is actually floater from other cases. This is like a hepatocyte. I'm not so sure if this tumor or not, but this looks like a hepatocyte. So this is not from our specimen. So you see, this is one section. This is the other section. We do not see here in the other section, right? So we need to pay attention when we see the like either the cytology or the cell block preparation. Floater can occur. So next specimen, this is a urine specimen. Avoid the urine specimen. The patient doesn't have any history, and he presented with gross hematuria. So this is a very cellular specimen for the voided urine. we do see like a lot of cells in the background, and some of them are showing these cluster arrangement. So when we go to higher power, this is definitely abnormal. So in the background, we have a lot of these big cells, but most of them show prominent degeneration. A lot of them showing these like a choreoresis type of pattern. However, we can still find individual cells with very high NC ratio and relatively degenerative chromatin pattern. And these cells are scattered throughout the entire specimen. And here we have a more hyperchromatic and coarsely like a coarse chromatin cells. And here we have very dark but pyknotic cells. So the abundance of these atypical cells, despite majority of them showing remarkable degenerative change, this is still diagnostic for high-grade urothelial carcinoma. So remember, this is the very first specimen for the patient who came to our hospital because of hematuria. So urine cytology is a very cost-effective tool for cancer diagnosis. And so you just pee and you get a specimen and you do the scan and you see these and you know the patient had high-grade urothelial carcinoma. So this is very convenient and very effective diagnostic tool. The problem is that sometimes we don't have this amount of cells. And so in our hospital, we usually, the clinician usually would order 3 different paths of urine cytology specimen just to increase the diagnostic sensitivity. So this is diagnostic for high-grade urothelial carcinoma. So we move to fine needle aspiration. The first case is thyroid aspiration. So on low power, no colloid, the cellularity is moderate. We do have some aggregates of the cells, but it's not hypercellular. So some of these cellular clusters do show a papillary, branching papillary architecture. So you can see some papilla over here. But for this type of area, it is very thick, a little bit difficult to see through. So for these, it seems to be like a microfollicular pattern, but we notice something in the center, in the core. This looks like a samoma body because we see some concentric like a lamination. So is it a PTC or is it a follicular tumor? So then we move to like a thinner area. So we start to identify. Here we do see a pseudo inclusion in the nucleus. There is another one over here, maybe a little bit indistinct on the television because it's too thick. But we start to see a typical nuclear feature of a papillary thyroid carcinoma. So again, if you can find one, we should find some more. So here another maybe a little bit indistinct, but there is a pseudo inclusion over here. So this is consistent with papillary thyroid carcinoma, despite we do see sort of like a microfollicular pattern, but in the center this is actually a samoma body because under the microscope we can see lamination. Okay, so for the case we will call these papillary thyroid carcinoma. So another pseudo inclusion, maybe more prominent over here. Yeah. So this is a papillary thyroid carcinoma. So next specimen is fine needle aspiration of a neck lymph node coming from a 71-year-old female. On low power, this is relatively scanned for a lymph node. But I would say just on this, like a very low magnification, you can appreciate they seems to be very, very scattered, very big cells comparing to the background, like a normal looking lymphocyte. So this is kind of abnormal. So when we go to higher power, let's just make sure it's in focus. Okay. So what do we see here? So we have the background of a normal looking reactive lymphocyte, right? But we do see big cells. If you're comparing the size of a normal looking lymphocyte, it is almost 5 times bigger than the normal looking lymphocyte. And additionally, some of the cell seems to have 2 nucleus and with prominent nucleoli. It's almost looking like a else, like a eye, like staring at you. So what's in your mind? This looks like Hodgkin cell, right? Yeah, so we see a combination of reactive lymphocyte, but a lot of these big cells and with very irregular nucleus. So this is a notch over here, prominent nucleoli, and we do see like this is just too big, and we do see occasionally they are typical binucleation cells with prominent nucleoli. Another one is over here that you can see. And the size of the nucleoli is almost as big as the lymphocyte, right? So these looks like Hodgkin lymphoma. This looks like a classic Hodgkin lymphoma with classic Hodgkin cells. But can we make such diagnosis in cytology? I think we can, but it's nice that we would have a immunostain. So for this case, I was debating, should I do just cytochemistry or should I do a cell block? Because there is a tissue that we received our Cytotech mark that there are some tissue fragment in the specimen. So I decided that we should do a cell block. However, the patient do had a concurrent core needle biopsy. I checked the biopsy. There is nothing over there. Yeah, so sometimes in the cytology specimen, it is more informative than the biopsy specimen. So they already sign out the specimen as like a crashed lymphocytes, something like that. Yeah, but here we do see very like abnormal cells, and the case is definitely suspicious for Hodgkin lymphoma. So we will wait to see whether our cell block is better than the biopsy specimen. Clinically, the patient do presented with multiple enlarged lymph node, and including in the neck as well as intra-abdominal. And lymph node is actually like almost obstructing bilateral ureter. So it's the case, I think, from the urine specimen that we received. Yeah. Yeah. So we had her urine specimen, but there's nothing in the urine. Another thyroid aspiration specimen. So this is much more easy because we have hypercellularity, classic arrangement, monolayer sheets plus papillary architecture, and we just need to go to high power to check the area. So here we also have some Samoma body over here, and we just need to go to high power to, especially to the monolayer area to see. So the nucleus are mostly oval and irregular arrangement with like a different long axial crossing with each other, and we just need to find pseudo inclusion somewhere, and these areas consistent with the cystic change area, so the cells become bigger, the nucleus is more rounded, And yeah, so sometimes it's not easy to find the pseudo inclusion, but this is diagnostic for papillary thyroid carcinoma, a very typical case. So here is a very tiny inclusion over here. There is another one over here. Okay, so this is consistent with papillary thyroid carcinoma. It's getting more common that we see this type of thyroid aspiration. So on low power hypercellular large fragment, we do not see any colloid at all. So if you don't tell me this is from thyroid, I have no idea this is coming from the thyroid. So on high power, we only see like a highly atypical cell with very tight cluster. Some of the cells showing a little bit spindling, like a squamoid type of pattern. In the background, we do see like a scattered area showing maybe they are some squamoid, like a differentiation. So the patient had a non-small cell lung cancer and with diffuse positivity for P40, so likely a squamous cell carcinoma from the lung. And this is thyroid aspiration. So this is likely metastatic squamous cell carcinoma to the thyroid from the lung. So I think metastasis is getting more and more common in our practice. So whenever we see a specimen, we always need to think about the possibility of metastasis. So for this case, if it is a primary thyroid tumor, what would it be? Would it be an anaplastic thyroid carcinoma? Because nowadays in the WHO classification, primary squamous cell carcinoma equal to the anaplastic thyroid carcinoma. But we always need to check whether the patient had a history. So here we have these keratinized cells, right? Yeah, so this is more likely to be a metastatic squamous cell carcinoma from the lung. So we will do some immuno for the case. So occasionally in thyroid aspiration, if we have a suboptimal specimen such as this one, so this is very pulsy cellular. We have only a few cluster of cells. So the cells do show some degree of nuclear atypia, suggesting that it is a papillary thyroid carcinoma. But because of the scan cellularity, for this case, I would prefer that we just call this suspicious for squamous cell carcinoma. So the aspiration is obtained from a very tiny nodule in the thyroid. So for in this situation, sometimes we just don't like push our diagnosis. Another similar specimen, there's nothing on the pap smear on the liquid-based cytology, but we do see these type of cellular cluster on our loose stem preparation. So again, so it does show feature of papillary thyroid carcinoma, but just because of the scan cellularity, and we would call these suspicious. So we have two suspicious for PTC case, two positive for PTC case, one metastatic squamous cell carcinoma for the thyroid. So that's for all the case today. Thank you.